Okay, welcome back, ladies and gentlemen. I wanted to take a few minutes to talk specifically about the concept of the revenue cycle as we know it in healthcare. And you'll see that this particular slide deck, if you look down here in the bottom left-hand corner, is 57 slides long. Some of this we're going to review in the fall, and I leave it in this particular slide deck for your benefit because you might want to dig into some of the different code sets and whatnot. So very quickly I'll show you. I'm going to cover basically in this particular session up through about slide 10. And then everything after slide 10 are many of the code sets that we are going to use repeatedly, and you'll hear referenced very often within the healthcare operating environment. So anything from ICD-10s to CPT codes to HCPCS to DRGs and MSDRGs and so on and so forth. So all this content, I don't want to bore you with it at this point, but you may again use this as a reference point for content both this semester as well as when we launch into the summer and then of course into the fall. So today though, I want to give you a very basic overview of what the revenue cycle really is, because as we start talking about working capital management, you can understand that we only get working capital available to us if we use the pure accounting definition. Working capital is, of course, the difference between current assets and current liabilities. Well, the only way that we get current assets, or more specifically cash, accounts receivable, and of course then we can use some of that cash to put into marketable securities. The only way we can do that is if we've got sufficient amount of revenue coming in the front door. So it's critical as healthcare leaders in the future that we're able to understand the building blocks, the steps in this process, so that when we do encounter problems, we, for example, see days in accounts receivable going up, right? And we're not collecting the cash as quickly as we should. Or if we see, basically receivables balances, we see coding errors, all this stuff ends up translating into problems with liquidity. And therefore, what we're going to talk about over the next few minutes are those critical building blocks so that when you do see these problems and you start to encounter them in the operational environment, you know what to do with it, right? Or at least you know where to start digging, at least know where to start asking questions. And that's really the name of the game. Because oftentimes, even the best experts in the field, when we start seeing problems with a given metric, when we're talking about financial ratios, we still don't know the exact root cause of the problem, right? And that's true also in the clinical lane, of course. But in the administrative lane, we've got to be able to dig down to figuring out what that root cause is, help fix it, help overcome it, whatever the case may be, so that, again, we can increase our liquidity to make sure that we can pay our people, keep the lights on, and continue to advance care. So first and foremost, this doesn't show up really great on the screen, but it's one of the best graphics that I've found that explains the full breadth and scope of the revenue cycle in the modern healthcare operating environment, okay? And so many people consider revenue cycle basically anything that's we're talking about with the patient visit up through about claim submission, right? We often hear people very narrowly focus revenue cycle in this space, or perhaps even we can go from life of the claim border here from left to right, okay? The challenge with that, of course, is it's somewhat myopic, short-sighted, and I would encourage you, especially as a healthcare leader, to start to consider the revenue cycle from very, very, very far in advance before any patient actually comes through your door. And some of the most significant ones are your contract negotiations, right? Your provider credentialing and your provider relations. This is where this starts to, these two critical elements really start to come into play. And if you'll entertain me for just a second, why this really matters. All right. Now, of course, with Medicaid and Medicare, when we start talking about contract negotiations, those are, well, I won't say non-existent, but they're severely more limited than what we might find with a commercial insurer, right? But those contract negotiations basically help us to establish what the rates are that we're able to charge for that particular payer for that particular episode of care that is going to be pursued for a given covered life or given beneficiary, right? So this is what establishes really the revenue point that we can actually bring in the door, right? Fee schedules, of course, we have what we call in the healthcare environment, or in the hospital environment in particular, the charge master, okay? And we're going to get into this a little bit deeper again in the fall, but that charge master is basically the full menu list of things or the services that we provide as an organization, and the charge that we basically at full menu price, right? Now, of course, that fee schedule is negotiated down by the payers, and depending on your organization, the amount of market clout that you have, how big or how small you are, right? Whether you're part of a larger system like a Tenet or an HCA, how much competition is in your environment, that all plays in the fee schedule and the negotiations that take place with regards to what you're actually going to get reimbursed. Thirdly, here, provider credentialing. You can't provide services for which you do not have a provider to do them, right? This is why physician relations are so important. This is why we spend so much time in this particular program speaking to the issue of, how do we interact with, how do we basically engage, how do we basically keep the provider happy, but also make sure that we maintain good operational sound principles and are able to help keep the organization moving forward. Okay. The rest of these are banking related, so I'm not going to get too in depth here, but all of this stuff, these top three, might happen months or years in advance before we actually see any patient come in the door. Okay. Depending on how frequently we have these contract negotiations, it might be every year, it might be every other year, it might be every third year, it might be every 6 months. It really just depends on the particular payer and the operating environment that you're in. Okay, so I'm not going to go down into all of these individual blocks just for the sake of time, but from a broad brushstroke standpoint, you have your pre-visit happening. Basically, when we start to actually originate a claim to which we are going to send to one of these payers that we just negotiated with or have negotiated previously with, right? We have a lot of different steps in the process to make sure that, one, we have the right person, the person is eligible for care under this particular carrier, that we have all of the correct demographic information, payer information, so on and so forth. Okay, so and there's a lot of good evidence out there, with regards to this. Also, of course, has a play or a role to play with respect to operations management, ensuring that you don't have basically no-shows, and of course also leave without being seen, because we have a lot of staff time invested into any patient appointment, even before they get through the front door and actually see a provider. So some of this pre-visit stuff, eligibility verification, scheduling and registration to make sure that the patient is able to make it, has adequate transportation assets, and really is not going to end up being a no-show, and then of course waste our providers' time and waste our staff time as well. So some of these appointment reminders and different methodologies to ensure that patient is aware of and can adhere to that appointment can be critical. The visit itself, of course, the patient check-in, copay and deductible collection, okay, and hopefully you understand the difference between the copay and deductible, depending on the size and scope of the procedure in place. In some cases, or in many cases, that patient payment arrangement needs to be established prior to the visit. That even could be in the pre-visit phase, although there's dangers in doing that. If you start discussing it at this length, people will just suddenly decide they can't afford it, don't want to go through with it, which not only compromises their care, but also can compromise your operational efficiency and revenue stream. Okay. Of course, when the visit actually occurs, we want to make sure we're documenting everything that happens. If it is not documented in a patient record, it did not happen, and you cannot bill for it. Okay, and that's part of the education process we often have with young physicians in particular, to make sure that they understand that what is the appropriate documentation to include, and this is partly where the electronic health record is helping us, but not in all cases. But that documentation, if it's not in the patient record, it did not happen. Okay, and then the back end of this in the visit, we have coding and charge capture, ensuring that one, we are not upcoding. Okay, if you have systemic upcoding, you end up sometimes in silver cufflinks that do not detach, and you get hauled off to prison, literally. But of course, we don't want to leave any money on the table either. So this is a very delicate balance here to make sure that our coders and our billers are coding the appropriate procedure that can be documented and basically supported through evidence that's in that patient record. Okay, and it really comes down to the common man sort of, or common physician sort of perspective. Would the same physician, or some group of physicians come to the same sort of basically determination and treatment protocol that what this particular record is showing us? Okay, so then of course we go into the claim submission process. Okay, and there's multiple layers to this. And you're seeing, and actually in the fall we'll probably revisit, as we did this year, the Parallon organization that is actually a subsidiary of HCA. What Parallon does, and Conifer is their kind of sister organization under the Tenet umbrella. But Conifer, what they'll do is they'll take claims and they'll collect claims from multiple different HCA facilities and do some of the pre-adjudication here, or basically run that claim through the process based on the protocols and requirements of that particular payer, right? That therefore, when what we're hoping for when we go through pre-adjudication, then what we want at the back end of this is what we call a clean claim. It doesn't get denied. It doesn't get hung up someplace. They don't come back to us asking for more documentation, so on and so forth. Okay, so we want that to happen. Okay, pre-adjudication, we submit the claim, and then we track it. Okay, then of course there's the inbound processing, and we actually get and eventually accounts receivable posted to the books, and then we track it that way. And of course, and you realize if you get into any large organization, okay. Let's say St. David's in Austin, or Methodist Stone Oak. How many patient encounters do you suppose that they have on both an in and outpatient basis on any given day? Okay, and recognize that hospitals don't shut down. Okay, they might slow down. There might be seasonal fluctuations, but this is a constant process. Okay, so if it's not efficient, if it's not effective, you can understand where we get a lot of money hung up in our revenue cycle. Okay, and right now, from this point to this point, on average, within the HFMA reporting environment, we're averaging about 52, 53, 54 days. Okay, from start to finish. Okay, so that means nearly 2 months of delay before the organization sees its money. Okay. That's on average. Now, of course, there's better operators and there's worse operators, but if we can decrease accounts receivable by a day, by 3, 4, 5, 6 days overall, we're talking about millions of dollars for any large organization. Okay, so the more efficient this is, the better we are. Now, I also want to touch on the back end of this, right? A lot of times, we often just get kind of lost in the sauce in between here, and we get so, basically wrapped around, what we're doing with regards to each one of these steps that we don't take the time to actually do some back-end analytics to really examine the quality of our process. Okay, one of our executive students has just done this as part of his performance improvement class, or our performance improvement class that I teach them. And he literally has done this to be able to look and break apart this process from a process flow standpoint, so that he understands where the duplication is, where the hangups are, where the bottlenecks are. Because as this flows more freely, okay, as we have a better physician relationship, right, and physicians are closing out their records, we're making sure everything is documented, we're going through pre-adjudication, so on and so forth. Very easy then to be able to reduce our total days in accounts receivable, okay, and our payers' denial ratios, and our rejection analysis. And if we do all of this stuff right in the pre-visit stage, and we start to treat people better, for lack of a better term, we start to handle some of their issues, and perhaps that might even mean, if we think about it from a pure business case standpoint, maybe we need to offer transportation assets. Maybe some of this needs to be done, basically in the patient's home. Who knows? And as we go into increasingly value-based purchasing environment, I think it's important that we start to think kind of outside the traditional healthcare delivery box, and start to think, how can we make things more patient-centered? How can we make things easier for the patient and the patient's family? And ultimately, I think at the end of the day, we can do well financially and still do right by the patient. Okay? So, again, probably the most beneficial slide or graphic that I've come across that can kind of show the entire revenue cycle, really from start to finish, and well beyond just the life of the claim sort of perspective. So the rest of the slides here within this particular short section deal with both the physician and the hospital billing process. And a lot of that, frankly, is somewhat similar here, but there are some different nuances and different terms that I'm not really honestly going to hold you to with respect to any homework. This is really offered so that you can understand kind of the steps in the process, and also understand some of the terms that might be thrown around, so that it doesn't throw you off too much when you start hearing them in the operational environment in your residency. So first and foremost, the physician billing process. And of course, we have the physician side that get paid their professional fees, and we get the hospital side with respect to, and I'm more the acute care sort of setting. What I'm not going to talk about, and it equally is important, behavioral health facilities, slightly different methodology. Of course, long-term care, slightly different data sets, slightly different methodologies. Home health, different. So don't think that this is the end or full expanse of the universe, but hopefully we'll also get you started with respect to really kind of thinking through what the process is in a couple of different environments. So first and foremost, from the physician perspective, of course, physician examines a patient, dictates the chart, okay, and sometimes this is directly, through DragonSpeak or other kind of dictation software programs. Sometimes this is an actual person that hears the especially you see this in some of our older physicians. They like to dictate it into a microphone, record it, and then someone will actually type the chart up for them. That's kind of going away in some areas, but still is part of our industry. And of course, then we want to mark any services performed in our electronic health record, selecting the diagnosis from a list of common use diagnoses within their basically their field of practice, right? The billing staff then enter the procedure and diagnosis codes into the billing system, and hopefully this EHR is helping us to do that. Of course, new physicians on a new EHR, that can be a complicating process, and sometimes young leaders like yourselves get involved with that education process and helping them to be more efficient and more effective, because the most valuable thing to a physician is time, right? So when you can save them time, this is how you can really get in good graces with these physicians, because when you save them time, you're basically putting money back in their pocket, because that means they can go and do something else. Okay, and then the billing staff create a batch file for submission, and we call this the HIPAA 837 data set. I don't expect you to remember that, but you might end up coming across it at some point in the future. Okay, payer notifies a physician that a claim has been accepted for adjudication or is rejected with a reason code. Okay, so this is where we can again, hopefully, if we can go use a processor, they will often do the pre-adjudication for us. If that does not occur, of course, that's the route that we would have to take through normal adjudication. Okay, payer adjudicates the claim, or again, adjudication simply means that they take that claim, they take all the documentation in support of that claim, and run it through their own protocols to ensure that all the documentation that is there, clinically appropriate, it supports the claim being made and the request for reimbursement. Okay, payer then remits payment. Typically anymore, that's electronic, transfer of funds to the physician and sends remittance advice electronically or via paper to the physician. Okay, and typically, again, this is more often than not electronic anymore, with the follow-up paper, and increasingly, even at that point, we're starting to see that that's becoming increasingly paperless. Really depends on the patient population, and sometimes that's an opt-in or opt-out with the individual member, especially with their explanation of benefits and the payment structure that's been arranged. Okay, so my OCD is getting the best of me here. And last but not least, bill or post-payment, and bills a patient for member responsibility unless that's already, of course, been collected as part of the co-payment and deductible sort of collection process I described on the prior slide. Some forms that you will hear a lot about are the CMS 1500. That's your professional paper claim form, and the UB04 institutional paper claim form. Okay. These, of course, have morphed into increasingly electronic versions. Okay, so just for your familiarity, this is kind of what a CMS 1500 looks like. And of course, here's a link that I encourage you to dig into if you want to know a little bit more about the 1500 and some of the nuances thereof. Now, on the hospital side, like I said, institutional claim form is the UB04. Okay. You might also hear it, again, this is the fun and joy of the modern healthcare environment. You might also hear it termed the HCFA 1450, used for both in and outpatient facility services, and we can go up to 450 lines. Okay, now this is coming across electronically, like I mentioned before, and we can use this one if you want to actually download a sample UB04 and the manual that goes with it. Okay, I would encourage you just know the forms, know the terminology with them. If you get placed into a set of circumstances where you need to know more, reach out to obviously you can reach out to me, but reach out to your financial services staff, your CFO, your controller, your billing office staff. They're going to be much more adept and well-versed in this content than you could ever hope to be right off the bat. Okay, and realize too, as we go back here, you could have, in a large organization, you could have 100 or more people involved in this entire process. Okay, and it's going to be touching multiple different departments, multiple different sections. Obviously, a lot of this falls under the CFO, the billing office, but at each one of these, and this is why as you start to look forward to your Lean Six Sigma class a little bit later in the curriculum, this is why a process map actually helps you to understand, all the steps, all the players, all the different bottlenecks that an individual or organization might encounter. So, with that in mind, it's really hopeless to think that we're going to get our hands around every single part of this as part of our curriculum here. But I want you at least again know the terminology and what we need to at least get you started on the pathway to being successful. Now, I also recommend. This is a really good site over at Johns Hopkins. These couple of links I'm going to pull over here, actually. Hopefully this comes across okay. And give you some indication of kind of the healthcare reimbursement. And this is a site that is updated frequently. You can see down here at the bottom, this was updated in early October of 2017. But primarily give you some idea of the different types of payment. So here we have facility payment summary, type of payer, Medicaid, or here under Medicare, you've got the different types of payment systems that you're going to see, and then kind of the different nuances to each one. Likewise, you go down here, facility payment structure, Medicare inpatient. You can see step 1, step 2. Find a payment amount by ops payment amount, ambulatory surgery centers, so on and so forth. So very useful, and this particular site might come in really handy not only for reference, but if you need to dig into different payment rates with respect to, for example, building a business case, understanding, if we use Medicare as kind of the baseline, and we'll talk about this more. If we use Medicare rates as a baseline, commercial gets paid, I typically use an inflation factor of 1.25 over the Medicare rate. I use for Medicaid, I use about 30% of what we get paid for Medicare. And then you can start to spin your numbers based on, what percent of your overall payer mix on any given service line is actually going to, be translated into hard green dollars at the end of the analysis. Okay. Another site or the other link that's on that Johns Hopkins site is this one. And lots of information with regards to, of course, the regulatory agencies that we talk about. They kind of have some oversight with respect to this particular area of our industry, but also has some great information, again, kind of as a good reference point on the different ICD-9s, 10s, different levels of HCPCS, MSDRGs, and then some of the, as he terms it, the alphabet soup with respect to some of the common acronyms. So I've found it useful, and I think some of our prior students have found it useful, just knowing where these sites are at. And again, you can click through them, and both of these will pop up with this particular link, or these two links rather. Okay, so with that, I'll go ahead and sign off on this particular session. Of course, you're more than welcome again to review all the content here. We're going to end up touching on all these code sets down here in the fall, but they're there for your initial review, and then again we'll pick it up as things pick up in the fall semester. So thanks, Happy New Year, and we'll talk to you soon.